Welcome everyone to the virtual live debate at the 2022 HIV and Women Workshop. Before we commence, I'd like to remind the debating teams that when you address me, you should use the term Madam Chair. So how will this work? We have the proposition, integrase inhibitors cause weight gain. One team has been asked to debate in favor of this, meaning that integrase inhibitors do cause weight gain. The other team will try to convince you that they do not cause weight gain. As with any debate, the teams are not necessarily arguing their own personal opinion on this matter, but they are going to try to convince you in the audience nonetheless. That's what a good debate is all about. Before I introduce the teams and the debate can begin, we need to know where you stand. We will ask you if you are undecided about the motion, in favor of the motion, or opposed to the motion. And I will summarize the voting proportions at the start. When the debate ends and the final rebuttal closing arguments have been made, we will vote again. We will compare the starting and the finishing votes to decide which team has won the debate. The team that wins will be the side that is able to change the most minds to their position from the other position, and or win over the minds of people who were undecided at the start without losing any of their initial supporters. So the side that's gained most in absolute percentage is deemed the winner. May we please have the electronic vote now. Here again is the proposition, integrase inhibitors cause weight gain. Are you undecided? Are you in favor of the motion? Are you opposed? If you can scan the code and enter this code, we can take your votes. I'll give you another 20 seconds or so to do this in case you're having, we've been getting pretty good at this during the workshop so far, so. So Sam, when should we close the poll? Is it time? There we go. Okay, here we are. We have 52% agree with the proposition. They do cause weight gain. 12% disagree, and 36% are undecided. So there's a work ahead for the team opposing the proposition to see if they can change anybody's minds and get them to move over. Okay. It's my honor to introduce our teams this afternoon. The biographies of all four debaters are in your program book, so I won't take up the time now to provide them. They are well equipped for this debate. Providing the healthcare provider perspective for the team in favor of the debate proposition, integrase inhibitors cause weight gain, is Chloe Orkin from Queen Mary University of London, United Kingdom. Chloe, go ahead, please.
The pro debate. Here are my disclosures. So the question is the inflammation related to HIV itself a factor in weight gain? When we look at the START study, what we see is that there are differential weight gains in those who start treatment immediately versus those who have deferred treatment, and that the weight gain is different depending on the viral load. And this suggests a role for inflammation, which is related to viral load, and suggests that there's actually a mechanism integral to HIV itself driving the weight gain. Why is that important? This is important because what we need to study is not people on PrEP, but people with HIV, because the mechanisms of weight gain may be different, and this may not be relevant to the discussion. I'll start with the integrase inhibitors and weight gain and first-line therapy. Lots of this debate began around the data presented at CROI in 2019. The NIR cohort data suggested greater increases in BMI over the first 2 years in those receiving integrase inhibitors versus PIs and NNRTIs, and they didn't establish any differences by race or sex. They further showed that people who were on second-generation integrase inhibitors, such as dolutegravir, gained weight at a faster rate than those on first-generation inhibitors. So this was the first evidence of causal association. When we look at first-line therapy studies, what we see is very varied and difficult to interpret findings. And this is related to the fact that they're very different populations. It's also related to the fact that these different studies looked at different categories. They observed both median and mean weight gain. So when you report a different variable, it becomes very difficult to compare like against like. And these cohorts are very different with respect to gender, race, age, weight, and other baseline demographics between clinical trial populations. So the eagle-eyed amongst you will have noticed that we were talking here about the third agent, but we didn't know what the effect of the backbone was. So can we remove the effect of the backbone and just look at the integrase inhibitors and what their effect was? Well, the answer is yes, okay, because this analysis, which is a pooled analysis of 8 phase 3 clinical trials, looks at weight changes in first-line treatment for those starting treatment between 2003 and 2015, showing greater than 10,000 person-years of follow-up. And this, because of the size of the analysis, was possible to stratify weight change by third agent, okay, and also by the NRTI backbone. So if we look on the left, what we see is integrase inhibitors in orange, showing statistically more weight gain than PIs and NRTIs. When we look amongst the integrase inhibitors, we see that bictegravir and dolutegravir are showing similar weight gain, but more weight gain than elvitegravir. And we look on the right, we can see that there is an effect of the NRTI. And we're seeing that TAF is associated with the highest amount of weight gain, more so than abacavir, which is more so than TDF and more so than AZT. So we saw that participants taking integrase inhibitors experienced the most weight gain, but TAF was also a factor. Does the weight gain affect everyone in the same way? Well, in the advanced study, which is a study performed at a single site in Johannesburg, we've seen very, very dramatic weight gain in women versus men. And you can see this throughout the study. And this is particularly evident at week 144, when we look on the left at dolutegravir FTC TAF versus the right at efavirenz FTC TDF. And we can see that in some cases, this is associated with treatment emergent metabolic syndrome. In the advanced study, it's also important to say that the weight gain was predominantly fat mass rather than lean mass, and women gained significantly more fat mass than men did. But also there were significant outliers who gained more than 10% change in their body weight and had significant treatment emergent obesity on the dolutegravir FTC and TAF arm. But this isn't only limited to South Africa. When we look at the NAMCEL study, which occurred at 3 sites in the Cameroon, comparing D2G TDF3TC versus TDF 3TC efavirenz 400, what you do see is a BMI difference in terms of the mean change from baseline, statistically significant differences for weight, for BMI, and also for treatment emergent obesity. So this is a different cohort. But going back to that original multivariate analysis of this very large study, what we see here, even in well-resourced countries, when we look at women and Black people outside of the African context, we're still seeing a weight change effect stratified by sex and by race. So this is a very important thing to notice. So in terms of take-homes, the take-homes are that weight gain with initiation occurs more in women, Black people, and Latinx people, and there's more with integrase inhibitors. Why this weight gain? Well, starting antiretrovirals and controlling HIV reduces inflammation and catabolic effects, especially in high viremia. So without this effect, if you eat the same, you'll gain weight. But is the weight gain the same for integrase inhibitors versus other third-line agents? My answer is no. What about switch? So in switch study, in the OPERA cohort, weight changes with switch from TDF to TAF while maintaining other antiretrovirals by class of anchor agent. You can see that between 0 and 9 months, people gain weight when you switch, but numerically, the changes were higher in the integrase category than the other classes. And once again, in the second generation integrase inhibitors, D2G, BIC, more so than elvitegravir. So in terms of a summary for weight gain in switch, weight gain occurred in antiretroviral experienced people, suggesting a different or additional mechanism that's not just reversible of catabolism or inflammation. There's some modulation of adipose tissue potentially, and the outliers remain a concern. So what is the mechanism? Well, increased fibrosis in adipose tissue, both VAT and SAT, has been shown in people with HIV on integrase inhibitors. And this is different from people not on integrase inhibitors. So I think that although the mechanism is complex, it's important to recognize that there is a mechanism emerging of how integrase inhibitors may be structurally different. There's accumulating evidence that integrase inhibitor-based treatment is associated with greater weight gain than other drugs, affecting Black and Latinx people more and women. Whether there are differences between integrase inhibitors is less clear. The role of TAF as additive, multiplicative, or neither is unclear, but the mechanism is clearly important and leaning towards a role for integrase inhibitors. Thank you for your attention.
Thank you very much, Dr. Orkin. Now, before we hear the community perspective for the proposition from Doreen Mora Maracha from My Beautiful Story, Kenya, we want to hear the provider perspective about integrase inhibitors cause weight gain. Against the proposition will be Daniel Karitzkis from the Brigham and Women's Hospital, Harvard Medical School of the US. Now, I do want to say, first of all, to everybody in the audience that we will have a debate. We'll open up the floor, but in the meantime, as you listen to what's being said, don't hesitate to put your comments in the chat. Do you agree with what you're hearing? Do you disagree? What aspects are being overlooked? If you feel strongly, try to influence other members of the audience. And if you want, you can add your name, institution, and country. You'll be able to ask questions. I'll field them to each team. And if you want a specific team member to respond, you can indicate that. And the debaters will be responding until the rebuttal speeches. So let's hear from Daniel Karitzkis. You are opposed.
Well, I'm pleased to present the argument that integrase inhibitors and other antiretroviral drugs are really not themselves responsible for weight gain. These are my disclosures. By way of background, we know that untreated HIV infection leads eventually to profound weight loss, so what we used to call AIDS wasting syndrome. So initiating antiretroviral therapy in previously untreated persons with HIV reverses this weight loss and causes weight gain as a return to health, really back to the normal weight that people ought to be. In addition, at least in the United States, we know the typical American gains between 0.5 and 1 kilo per year from early to middle adulthood, resulting in obesity over time. It's also clear that attitudes about body image and ideal body weight vary widely across different cultures. These data from the National Health and Nutrition Examination Survey conducted by the US Centers for Disease Control and Prevention show the average weight over different age groups. And you can see how the typical adult male goes from about 185 pounds to 202 or 3 pounds. And the typical woman goes from about 162 pounds to 170 pounds between the ages of 20 and 50. Now, antiretroviral therapy can have an effect on this weight gain in surprising ways. So first, let's look at what happens in people without HIV infection. And there's good evidence that tenofovir in the disoproxil fumarate formulation is associated with weight loss in a series of PrEP studies. This is a meta-analysis conducted by Andrew Hill and his team, and it shows clearly that there was a significant odds of having at least a 5% reduction in weight in people who were randomized to TDF, usually TDF plus FTC, as compared to the placebo group in a range of TDF-containing PrEP trials. In addition, in the Discover study that compared FTC TDF to FTC TAF for PrEP, we see some surprising results. In contrast to the typical weight gain that would be expected over time in a population of young adults, remember that this study was done in MSM and in transgender women, we see that there's essentially no weight gain over 96 weeks with maybe a half kilo at the very end. And by comparison, the individuals who were in the TAF arm had about 1.5 kilos weight gain over 2 years, still a little bit less than might be expected for this age group. So the notion that TAF is promoting weight gain over and above what might be expected is really hard to justify. Now, granted, there's no control group here of people who received no antiretroviral therapy. It's also conceivable that people in this study were unusually physically fit and paid greater attention to their weight through diet and exercise. There's no evidence from this study any increase in weight from a TAF-containing regimen greater than what would be expected in the population as a whole. Now, if we look at the Gemini study, which is the study of dolutegravir 3TC versus a traditional triple drug regimen with TDF FTC as the nucleoside combination together with dolutegravir in treatment naive people, here we see the 144-week follow-up. And what's notable is that everyone is getting dolutegravir, so they're all receiving an integrase inhibitor, second generation INSTI, but there's a substantially lower increase in weight in the people who also received TDF, as you can see in the orange bars. This was true at both 96 and 144 weeks, and it was true in men and in women. So there's clear evidence that TDF is somehow weight suppressant. In the Tango trial, which was a switch study in people already on a suppressive regimen that had to be on a TAF regimen, they either continued on their TAF-based regimen or were randomized to dolutegravir 3TC. Overall, there was about a 2-kilo increase in weight across both groups over 144 weeks. Again, somewhat less than might be expected for this age group. And no significant differences, although there are some minor differences within different weight groups. Obese people had slightly different trajectories than people who entered the trial who were underweight or normal weight. If we look at SALSA, another switch study, this took people on any regimen, didn't have to be a TAF-based regimen. You can see the breakdown in regimens. So over there on the right-hand side, there was a greater increase in weight in the dolutegravir 3TC arm, but that's because they started off slightly lower weight than the group that was on that continued on their baseline regimen, who had started with roughly 2.2 kilos more weight, had a slightly lower weight gain. At the end, there's about 1.5 kilos difference between the groups, which was not statistically significant. Most notably, if you look at those who continued on a TDF regimen versus those who had a baseline TDF regimen versus those who did not, there was more weight gain in people who were stopping TDF, again, suggesting liberation from some weight suppressing effect of TDF. The Drive Shift study looked at, again, a switch trial in people who were suppressed on mostly boosted PI regimens, a few on boosted elvitegravir, and around a quarter on other non-nucleoside RT inhibitors. You can see that in this longer-term follow-up of that looked at early versus delayed switching, we can see that there was an increase in weight as people shifted off of their boosted PI, suggesting, again, the boosted PI is causing a suppression of weight gain, perhaps because of diminished appetite. And here in this TAF switch study, we see that there is a transient increase in weight during the 9 months around the switch to TAF, and then a stabilization that resumes the previous curve of increased weight over time. So in summation, weight gain is common amongst adult populations. Weight gain upon initiating ART in persons with HIV is due at least in part to return to health. Some antiretrovirals, such as boosted PIs, tenofovir, and possibly efavirenz, have a previously unappreciated effect on limiting weight gain. This apparent excess weight gain associated with second-generation INSTIs and TAF reflects loss of this suppressive effect.
Thank you, Dr. Karitsky. And audience, keep on coming with your comments and your questions. We're going to be putting our debaters on the spot soon. But now I'll call upon our next speaker. The second speaker for the proposition is Doreen Mora-Maracha. You have 4 minutes to convince us that the proposition integrase inhibitors cause weight gain still holds. Doreen.
Hello, everyone. I am representing the community from the pro side on integrase inhibitors cause weight gain, and I have no conflicts to disclose. So do ARVs cause weight gain? I believe they do. That is according to my experience as a person who has been on ARVs for the last 17 years. My experience as a person who has lived with HIV for the last 29 years, have been on ARVs for 17 years as well, I started ARVs when I was 40 kgs and I had a CD4 count of less than 250 copies. However, as time progressed, I started gaining weight and my CD4 count doubled as well. However, 3 years into using ARVs, my legs started thinning while my mom started gaining visceral weight. I complained to my doctor, who brushed it off at the time and said it was a normal reaction, but my legs didn't stop, as well as my mom's weight gain, until we were told it was time to be switched to another regimen because the stavudine-based regimen had been proven to cause lipodystrophy and was phased out. Sometimes I wish I had taken the nutritionist seriously because at one point when I was 23, I weighed 100 kgs and I can't, as much as I can't remember the regimen I was on then, but I went through another nutrition class to remind me on why I need to work on my diet. My weight went down to 95 kg, but it never went down anything below 90 kgs while I was on the tenofovir, lamivudine, and efavirenz-based regimen. I refused to be optimized to TLD because I had weight gain concerns. But in 2020, my doctor insisted that I didn't have a choice. And I remember making a post on my Facebook page and most women telling me now I should prepare for the weight gain coming my way. I was 91 kgs then. I thought, how worse could it get? Well, 2 years into TLD, now I weigh 124 kgs. From last year, September, where I weighed 114 kgs, and I was warned by my healthcare provider that I should look out so that I do not expose myself to more non-communicable diseases. But I started now switching to working out, eating 1 meal a day, and even doing intermittent fasting. None of it worked. And so far, my weight graph keeps going up. And as much as I come from a family of big-bodied women, my ARVs are not even helping in ensuring that I maintain proper weight that does not expose me to diseases such as diabetes. I have done discussions on ARVs and weight gain on my social media, and most responses I get from women are about weight gain and visceral fat, while some have not gained any weight at all. We consider them lucky. I've talked to my doctor a number of times to have my regimen changed, but he insists it will soon kick in and I'll go back to weighing less than 100 kgs. I don't know when, but how many women are going through the same thing as me? How many of them get body shamed for being overweight? Just recently, somebody on my social media called me obese. Did it make me feel bad? Of course. Reason being, the person behind the keyboard does not know my struggles on being on medication that have to keep me alive, but also they have to keep me being overweight. ARVs are here to help people living with HIV not look like they have HIV, basically. But what if some of them are exposing people living with HIV to more problems? Because weight gain comes with its own fair share of problems. My suggestion will be let healthcare workers keep an eye on patients with an increase in weight gain and switch them to a different regimen very early. Train healthcare workers on integrase inhibitors that cause weight gain to look out sooner. Teach people living with HIV on proper nutrition habits, especially those on regimens with integrase inhibitors, and continue advocating for friendly regimens. At the end of the day, the goal isn't just health, but wellness in general. Thank you.
Thank you, Doreen Mara-Maracha. Some strong arguments there. I'll now call upon the next speaker. So this is the second speaker for the opposition, and it's Angela Nabiba. Angela, you have 4 minutes to convince us that integrase inhibitors do not cause weight gain and we should reject the proposition. Angela.
Thank you very much. My name is Angelina Nabiba, and I'm going to be speaking against the proposition that integrase inhibitors cause weight gain. We know the reality is that over the past 2 decades, global trends have shown an increase in weight, increase in the general population over time. And this is across lots of different countries and lots of different continents. But we also know that weight gains and rates of obesity in people living with HIV is very much similar to that of the general population. So, this is why I miss face-to-face meetings. But for now, what I'll just say before I continue, please type yes in the chat if you have put on weight in the past 5 years. I think you'll all agree that many of us have put on weight in the past 5 years, right? But the reality is that as a population, we're doing less, we're eating more, we're meeting less, we have more screen time, and we have more choice on what to eat and also access to what to eat. So for example, down my street, in a 5-minute walk, I have access to more than 30 or 40 restaurants, cafes, bars, supermarkets where I can actually access food. But we also know that those who are losing weight are the gym bunnies amongst us who are actively trying to keep fit. And of course, those people who are unwell. And so when we're interpreting weight gain with people who are taking integrase inhibitors, we need to look at these environmental impacts and factors. We also know that there are actually lots of other intersecting factors, including ARTs, that can affect our weight as people living with HIV. There's genetics, the diet that we eat, in the different populations. There's also people who have comorbidities. Some of these illnesses make us put on weight, but in line with that, some of this medication that we take for these comorbidities can also make us put on weight. We also know that when we're actively encouraging people to test early, so they're diagnosed earlier, they're starting treatment earlier. These integrase inhibitors are less toxic drugs, they're better tolerated, and so people are taking them while they're adhering, and they're living well, healthily, and living their best lives. The other point I'd like to make is that we need to always stop looking at weight gain as a bad thing. The study here showed that actually, even though the women who were taking ARVs did put on some weight, it was actually compared to their HIV negative counterparts, the weight that they put on was near to, but not actually up to the weight gain that is recommended in the second and third trimester based on the Institute of Medicine standards. And what the study also showed is that weight gain was significantly associated with the lower risks of problems during pregnancy. So we need to stop looking at weight gain always as a bad thing. And last but not least, of course, there are risk factors for us people living with HIV gaining weight. But actually, the reality is that it is in line with the general population we are putting on weight, and there are lots of other reasons and benefits for us putting on weight. And I'll just speak on in a couple here, return to health. Aging, putting on it is part and parcel of aging. So for example, for me as a menopausal woman, I've put on age over the years. I've got 2 or 3 bellies, but that's, part and parcel of my aging process. And so please, let's stop penalizing these better tolerated, less toxic drugs by also focusing on the weight. And I'll just finish by saying that actually I started taking medication in the earlier years, and I was a svelte size 8'10" for many years, but actually it was at the risk of, I had severe gastrointestinal problems, which is just severe diarrhea to you and me. So, my quality of life wasn't as good. So please, let's stop penalizing these less toxic, better tolerated drugs in arguing about the weight gain. Thank you very much.
Thank you, Angelina Nabiba, from the Forum Network of Mentor Mothers. I'd like to thank all 4 of our speakers and invite them all to join the virtual platform live. That seems to be happening now. And I'm opening the debate from the floor. I just want to remind you, this is the opportunity for you to join in the debate. Please use the chat to give your own opinion and indicate what makes you think that way. You can ask any debater a question that you would like about their arguments for and against the proposition that integrase inhibitors cause weight gain. You can ask for clarification. You can comment on the strengths of one of their arguments. You can make supportive comments on either side. You can disagree with the points that have been made. So we have been collecting questions and comments. So I'm going to have a look at them now and start to field them. And then at the end, the debaters will answer any questions that are posed now to the best of their abilities, but at the end, they will make their closing arguments in the rebuttals. So let's see what we have in the chat and who is it for? I see there is a question here from Susan C. for Chloe Orkin. Why do you think women and Black people are more likely to experience weight gain from integrase inhibitors? This is Susan Cole from NAM AIDSmap UK. Somebody you probably know.
I do, and thank you so much for the question, Susan. Nice to hear from you. So you've asked a really important question, and the question you've asked directly proves the argument that I'm speaking to. And this is because nobody understands the mechanism as to why some people can gain such an unbelievable amount of weight. and what it is about these drugs that is triggering off a biological process that causes people to gain an enormous amount of weight. Not everybody, but some people. And it's precisely the fact that we don't understand this at all, and the fact that there are biological changes which happen in the body when you do a fat biopsy, when in people who've been exposed to integrase inhibitors, that underpins my argument that something biological is happening, and we don't yet understand the genetic effect. And what we do know in the history of medicine is that when we don't understand things, we tend to say that things are just in women's heads and this isn't really happening. And this has been something that's happened throughout medicine, most recently with hyperemesis gravidarum, where women vomit during pregnancy and they're ignored and told that they're just having morning sickness. When actually, in fact, what's now been found is that there's a gene that causes women who've been systematically ignored and told that they're making this up in their own heads. And similarly, there are women who are gaining enormous amounts of weight disproportionately for reasons that we don't understand, probably due to the fact that these drugs are triggering some genetic process. So I think it's really important that we don't ignore this finding just because we don't understand it, and that there are outliers in our trials who are gaining 10% amount of weight gain or more. And this is something that we should be very seriously considering and worrying about.
Thank you, Dr. Orkin. Now there's a question for Daniel Karitsky. I'm convinced, this is from Leopolda, I'm convinced that there's a weight suppression effect with TDF. And my question is that a healthy weight suppression in some people who are interested in medical therapy for obesity? Do the benefits of TAF outweigh the weight suppression benefits of TDF? So there's kind of two questions there.
Yeah, so I think that the issue around TDF and potentially other drugs like boosted protease inhibitors, boosted integrase inhibitors, either causing weight loss or suppressing secular trends in weight gain, represents a toxicity of those medications. It's not a metabolically based interference with normal hormonal signaling for appetite, but for example, in that same Andrew Hill review and meta-analysis, they found that there was substantially increased incidence of nausea and GI side effects in individuals who were receiving TDF-based PrEP. And so I don't think you want to use a toxicity of a medication as a means of achieving what might otherwise be a desirable outcome of weight loss for people who are trying to do so. And so I think that it gets at both of the aspects of this question. It's probably not mechanism-based, but toxicity-based, well, because of the GI intolerance, and that therefore you wouldn't want to use this for weight control.
Thank you. Okay. Chloe Orkin, another question for you. This one from Hanisha Mohan. Were there any glucose tolerance studies in patients who demonstrated weight gain while on integrase inhibitors? Have we seen any of those? So
there have been studies looking at, particularly in the Tango study, there was quite a lot of studies, quite a lot of investigations around insulin resistance, HOMA-IR, and various measures of glucose and lipids to try and understand insulin resistance. But I think there are mechanistic studies, small mechanistic studies now looking at glycemic clamps to try and understand if there is an association, a metabolic association with these changes. My understanding is that the current thinking is that obesity, the obesity associated with the weight gain, is driving potentially a lot of these changes, and this might be the underlying pathogenesis. But once again, I think this is talking about the general population, and I completely agree in many respects with what Angelina had to say, as I always do, in the sense that we're all gaining weight. This is just a fact. This is really unfortunate. And, you know, I certainly see that, whatever. If you look at my photograph from viral education from a few years back, I've got a bit more on the cheeks. And I'm not on integrase inhibitors. But the important thing to say is that it doesn't explain the outliers. You know, what is happening, what is being triggered, that, you know, that these drugs are triggering switching something on in people's bodies. And I think that's where I really believe that there's a biological argument. And I think that we will see when we start to do more sophisticated trials, it'll be interesting to see what things like glycemic clamp studies will show, and further analysis of tissue and what that will actually show.
Thank you, Dr. Ork. And just a comment here, I think mainly for Doreen, is just saying, this is from Tatenda Bila, it's good to hear testimonies because I also have tried a no-starch diet and have given up because I either maintain my weight or gain a bit. So people are appreciating what you shared, Doreen. There's a question for Daniel from Hanisha Mohan again. This is, weight gain is dependent on the medical health status, whether you're diabetic, impaired glucose tolerant, or being obese, or having a metabolic disease. Change may not be seen in these studies, reflecting what the inclusion criteria were for the clinical studies. Can you provide some thoughts about the type of patients that are being recruited to these clinical studies, and are they representative of everyone?
Well, I think that's a terrific question. We always have to be concerned about generalizability of results from any clinical trial based on who was permitted into the study based on the inclusion and exclusion criteria, and how broadly the study recruited from the population for whom the results are intended to apply. I think the vast majority of studies of either initial antiretroviral therapy or switch studies have not excluded people because of presence or absence of diabetes and glucose intolerance and the like. It is interesting to your point, though, that when you look at the extent of weight gain based on baseline weight or baseline body mass index, there really are differences. And that came out in that switch study that I showed the data for earlier, where people who began with obesity actually had a decrease in weight during the trial, but then came back towards their pre-study weight baseline, whereas those who were not obese at the beginning, whether they were underweight or were normal weight, all showed an increase in weight over time. So certainly there are going to be individual differences in how people change or gain or lose weight over time on different antiretroviral regimens. And I think, as in everything else in medicine, while we look at aggregate data in clinical trials, when faced with a particular patient, we want to individualize our approach.
Thank you. Okay, here's a question I'm going to address to both teams, and it's from Teresa Otieno. We're all excited about injectable ARVs, but also concerned about weight gains, especially women. Should I be concerned about switching to injection? So we'll start with you, Chloe. What do you think?
Well, based on the weight analysis that was performed recently, what's been shown is that the weight gain is very similar to the weight gain you would expect when switching. So the comparator group, who were then switched onto cabotegravir or piperine, gained similar amounts of weight. So it's a switch study. We're not talking about a first-line therapy usage here. So we're removing the return to health effect for the switch therapy. So essentially, what we saw in the Atlas and the Atlas 2M study was around a 1 kilogram weight gain on both arms. For the FLAIR study, which was an originally treatment naive population, there was a 1.5 kilogram weight gain, and there would have still been some slight return to health effect there. But essentially, you don't see very different weight gain than you would expect on an integrase inhibitor. So not particularly so far in the trials, but the trials have recruited a predominantly male population.
Daniel, what would be your opinion on this? Should they be concerned?
I have to first acknowledge, of course, that my worthy opponent was a lead investigator in those trials and knows the data intimately. I would make the point that over the course of those studies, the increase in weight was no different than the increase in weight in people without HIV infection on no antiretroviral medications, let alone no integrase inhibitors. It's about a kilo or so every couple of years, and that's the expected weight gain. I would also point out that in those individuals switching from a boosted protease inhibitor regimen, they are giving up the negative effects of the boosting agent, be it ritonavir or cobicistat, which because of their known GI side effects are apparently limiting intake in ways that are more subtle than we may have recognized in the past. And this may get to a question you're about to ask us, but I would not have concerns about people switching to injectable cabotegravir or piperine on the basis of weight.
Thank you, Daniel. So there's a thank you to you, Doreen, from Isabel N., who says, in my group of women living with HIV, I have seen a huge increase in weight, all on integrase inhibitors. When they switched medication, weight was lost. So that is a clear indicator of weight gain due to integrase inhibitors and the benefit of switching medication. Now, there's a question to the whole panel. You know, weight gain is correlated with eating behavior. Have there been any studies on integrase inhibitors affecting satiety hormones in humans? So the sense that you've eaten enough. Do we have any indication that the feedback loop is not working?
I'm happy to try a bit here. So there have been, I think initially with dolutegravir, there was quite a lot of work on satiety and on various different hormones, which I don't understand because I'm a humble HIV doctor, not a metabolic doctor, clever metabolic doctor. But what I think is the case is that I think there was some concern that there was something to do with sleep hormones and satiety in terms of the nature of dolutegravir, but that was found not to be the case. So I think there's a lot of work on the mechanism and whether integrase inhibitors are affecting what we eat and how much we eat, or whether it's actually something to do with what actually happens to the nature of the fat. And my appreciation of the data, such as it is now, is that the strongest evidence is really looking at the composition of the fat, the fibrosis, and how fat changes on integrase inhibitors when you switch away from protease inhibitors and NNRTIs, and the composition of the fat. Now, whether this is a return to normal effect or what healthy fat would have been without HIV is immaterial to the debate, because the debate asks whether switching to integrases causes human beings who are on treatment to gain weight, not whether this is a return to normal or a good thing. It asks whether you gain weight. And clearly, for people who start on therapy, obese or overweight, and gain 30 or 50 or 60 kilos, this is not a good thing.
Daniel, do you want to respond before we go to the next?
Well, I guess I would say that I interpreted the question slightly differently. It's not, the question is not whether people gain weight on any particular regimen. It's do the drugs cause the weight gain? Are they responsible for the weight gain? Because as we've all agreed, I think everybody gains weight over time. And so the issue is the weight gain or the greater increase in weight a consequence of the regimen? I cannot dispute the possibility that in a subgroup of individuals, there is a different mechanism at play due to genetic susceptibility or some factor, but that in populations at large, taking all comers on average, there is, so not just looking at outliers, there is no evidence that the integrase inhibitors actually lead to an increase in weight due to the integrase inhibitors, as opposed to removing the negative effects of the other drugs or the effects of HIV.
Thank you, Daniel. So there's a question from Fungi for Angelina. So it is a more general question. What would your advice be for women gaining weight to not get depressed about it? Any tips you would share?
Mute myself. Thank you, Fungi, for that question. You just had to give me the challenging one, didn't you? Right. I think for me, what I would say, I mean, a couple of things really. Firstly, I think you can try the traditional stuff. So you can try healthy eating, healthy living, so exercising, maybe walking, swimming, if that's what you like to do. However, if you do those things and you don't lose the weight that you want to lose, or you're not able to go back to your pre-weight gain weight, because that may not be possible, I think it's also about learning to accept and to love your new body shape. and just saying, well, you know what, okay, this is not going to change in the next year or weeks or months or whatever. So learn to love your new body weight and zhuzh up your clothes. I mean, Doreen, I look at your posts and I see how absolutely proud you are of your body, of your shape, of your life, and I love your outfits. So I think it's also about when you learn to accept that this is not going to change, and if it's not harming your health, just learning to love yourself. I mean, as I mentioned, I've put on weight over the years as well. I used to be a svelte 8, 10, 12, but my peepees have all grown now, but I'm learning to just love my blessed self. I'm blessed. So I think it's about just changing your mindset to accept what you can't change and to work with what you've got, as long as you keep an eye on your health.
So thank you, Angelina. Doreen, just a question about, have you got any suggestions for other people about how to engage their physicians in such a way that you can share decision-making around ARVs and weight gain? Have you had experiences where you've tried and physicians are just not grabbing it, not willing to engage on weight gain?
Thank you so much for that question, Kathy. So for me, I would say sometimes the physician might not listen to you. It doesn't mean that you should give up altogether. You have a concern. This is your body. You live in this body. So you see it every day. You see it growing. You see it thinning. You see everything. So always ensure, because when when my legs started thinning out, and I told my doctor, my legs don't look like this every other day. So I know something is happening. And she insisted that everything was okay. And we kept going back and forth. Okay, I am sorry, but I used a threat on her, and I told her I was not going to take my treatment if she did not listen to me. So, but I'm not saying that you go that way. Just saying that talk to your doctor, because the more you talk to them, the more they actually now start seeing that why are you complaining so much, and is there an issue? If there is an issue, they will always actually change you from that current regimen, because right now the weight gain concern is there, especially among women living with HIV. And as soon as you speak out, most of the doctors have now even started considering that they should change the regimen after consultation, that is, and also encouraging the women to start taking better care of their nutritional needs.
So I'm going to send the question now to Chloe and Daniel about, this genetic issue. I mean, how could we tease this out? How can we figure out if there is a genetic susceptibility or predisposition to weight gain on any ARV?
I'll take a stab first, Madam Chairwoman, if I'm permitted.
Don't call me Chairwoman, just call me Madam Chair.
Madam Chair, I'm sorry, I thought that you'd given slightly different instruction, but Madam Chair. Oh, yes, Madam Chair. Otherwise, it's a redundancy. Yes. I think the way to do this would be to have a large database that included diverse populations who are otherwise well matched, on whom we have genetic information and could do the kinds of global genetic analysis, the GWAS analysis, that would require probably tens of thousands of people in order to have adequate power to discern whether there are particular genes that, first of all, are governing weight gain or BMI, and secondly, whether those have an interaction with specific antiretroviral regimens.
Thank you. And Chloe, we have just 30 seconds left for you to respond on that. How could we figure out if there's a genetic predisposition?
I completely agree with my learned opponent. I couldn't say it better than he did.
Okay, great. All right. Well, thank you, all of you. You have been absolutely brilliant. We'll now move to the rebuttal speeches. Let's see what you have to say. And speaking for the proposition integrase inhibitors cause weight gain, we have Dr. Chloe Orkin.
Thank you. So my rebuttal will center on, firstly, to say congratulations to my very learned opponent. And I've been dreading debating what the cleverest man in the world. But anyway, here we are. So I'll press on. So I would say to my learned opponent that the PrEP argument which he made is irrelevant to the discussion because we are not discussing the non-HIV state. We're talking about integrase inhibitors for HIV treatment. So I would I'd urge you not to consider that argument. There was a lot of discussion from my learned opponent in which he made excellent points on the contribution of TAF. But this has not formed the basis of my argument and TDF, because we all accept and know that TDF undoubtedly causes weight loss. But when, as I showed you in a very clear and very large meta-analysis of more than 10,000 patient years over 12 years of analysis, what I showed you is that when you adjust for the effects of TDF, you control for the effects of TDF, you take TDF out of the equation and other NRTIs out of the equation, what you see is a statistically significant a greater weight gain for integrase inhibitors versus all of the other classes. And you also see that second generation inhibitors cause more weight gain than first generation integrase inhibitors. And that's got nothing to do with return to health because all of the people would be experiencing return to health. This is first line therapy study. Also, when my learned colleague referred to the drive shift study, he explained that he explained the situation in switching to Duraviron, which is an NNRTI. However, what he didn't show you, or what I may have missed, is that there was a differential analysis looking at the effect of the weight gain, where the people switched away from an integrase inhibitor, a protease inhibitor, or an NNRTI to Duraviron. And what was shown is that the smallest amount of weight gain occurred in those who switched away from an integrase inhibitor.
Your time is up, madam. Thank you. And I saw you laud your opponent and then stick the knife in. So now let's hear from Dr. Daniel Koretsky against the proposition. He will argue integrase inhibitors do not cause weight gain. Daniel.
Well, I would like to congratulate my esteemed opponent in making very worthy arguments. Nobody has as broad a grasp of the clinical trials data as does Dr. Orkin. However, I feel that she is missing the point and overly dismissive of the issues with PrEP and TAF. The point is not that people receiving PrEP are similar to those with HIV infections starting antiretroviral therapy. The point is to illustrate the clearest example of how antiretroviral drugs may have negative effects on weight, presumably because of their GI toxicities. There's no question that the studies that Dr. Orkin cites show significantly greater weight gain on integrase inhibitors. That's because they are largely comparing people who have previously received a boosted protease inhibitor with drugs known to have severe GI intolerance, or in the case of first generation integrase inhibitors, to have been on a boosted integrase inhibitor, because most of those data, certainly in the SACS analysis, were limited to Gilead studies, and so those were people on boosted elvitegravir. Likewise, we know that efavirenz is recognized increasingly as having other unwanted effects, and these apparently extend to appetite as well. The last point I would make is that we have to look also at what era studies were conducted in. Many people on first generation inhibitors, at least for raltegravir, may still have been receiving older nucleoside backbones, which also have adverse effects on appetite and weight.
Thank you. The debate is over. Let the voting begin. So are you in favor of the proposition? Opposed to the proposition? Are you still undecided? Or perhaps has the debate led you to become undecided? We'll give you a minute here to vote, and then we'll pull up and compare the starting with the finishing votes. And I do want to thank the entire team. The debating teams on both sides have been very convincing. Very strong arguments. So Sam, have we given enough time for people to vote? Have a similar number of people voted to last time at the start? Ah, well, it's pretty clear. This was a very strong side. The integrase inhibitors caused weight gain. They have not only kept their 52%, but they've gotten all these undecided people to come over to them as well. So let's applaud the winning team. And I want to thank the debating teams for the thought-provoking arguments, and to the audience for engaging and letting your voices be heard. This has been a great debate. Thank you all.
Thank you.